It's Medicosis Perfectionalis, and this is my cardiac pharmacology course. Today we'll talk about another topic, antiarrhythmics. We divide antiarrhythmics into four main classes of medications. The first one is called sodium channel blockers. Second one is the beta blockers. Third one, potassium channel blockers. Fourth one is calcium channel blockers. And here is the mnemonic: smoke better pot in California. Horrible mnemonic, but it works. We divide arrhythmia into two categories: the abnormal impulse formation or abnormal impulse conduction. If it's due to an abnormal impulse formation, this is a problem in automaticity. If it's an abnormal impulse conduction, we call this a re-entry phenomenon. Tachyarrhythmia. So we have bradyarrhythmia when the heart is so slow, and tachyarrhythmia when the heart is so fast. We divide them into two things: supraventricular tachycardia, above the ventricle, because the atrium is above the ventricle. So basically this is atrial. Ventricular tachycardia is ventricular. Of course, this one is worse because your ventricle is way more important than your atrium. What happens when your cardiac output decreases? You get some CNS symptoms and CVS symptoms. CNS, dizziness, syncope, and convulsion. CVS stands for cardiovascular system, not the pharmacy. Palpitations and sudden cardiac death. Do you remember the two types of arrhythmia? Yes. How do we treat the abnormal impulse formation? By restoring the normal sinus rhythm. How do we treat the re-entry arrhythmia? By canceling the ectopic beats. How do antiarrhythmic medications work? They either alter the firing rate or prolong the refractoriness. These are the four classes of antiarrhythmics. You can add class 5, which is miscellaneous, such as adenosine and digoxin. We have two types of action potential. We have the muscles of the ventricle and the nodal tissue, SA node and AV node. These are totally different. The muscles of the ventricle are known as non-nodal. They are also known as fast response fibers. These are known as the slow response fibers. This is the pacemaker potential. As you see here, they look different. How do we treat the arrhythmia that happens here? By class 1 and class 3 antiarrhythmics. How do we treat the arrhythmia here? By class 2 and class 4 antiarrhythmics. 1 and 3 for the muscles of the ventricle, 2 and 4 for the SA and AV node. Let's start with the muscles of the ventricle. You have phase 0 and then phase 1. 2 is the plateau, and then you have phase 3 and then phase 4 and back with phase 0 again. Why do we call it phase 0? Why not just start by phase 1? They are trying to tell you, honey, that phase 0 is depolarization. Anything else is repolarization. That's why. So what happens in phase 0? Depolarization. Sodium rushes in. You know, remember the nerve physiology? Yep, sodium rushes in. And then phase 1, what happens? In phase 1, 2, and 3, these are the repolarization. Basically, potassium is exiting. So phase 1, potassium goes out. Phase 2, potassium is also going out. Phase 3, still potassium is going out. But we add some stuff. So in phase 1, we stop the sodium influx, and then there is some potassium efflux. That's why it's going down. But then phase 2 is the plateau. Plateau. Why? Because calcium influx coming in is balanced with potassium efflux coming out. Positive for positive. Great. Phase 3 is the potassium efflux alone. That's why we go down quickly. And then phase 4 is the resting membrane potential. We have the normal sodium-potassium pump, which is primary active transport, and the sodium-calcium exchanger, which is the secondary active transport. And of course, we've talked about them before in my video about digoxin. This was video number 12. Depolarization, sodium rushes in. And then number 1, we stop the sodium influx, and then we start the potassium efflux. Then calcium comes in, potassium comes out. 3, potassium comes out. And then 4, resting membrane potential. Thank you so much, sodium-potassium ATPase pump. Phase 0 is the sodium influx. This is rapid depolarization. The rate of depolarization depends on the number of channels opens. The greater the number of open channels, the greater the depolarization, or the faster the rate. Then, phase 1, we stop the sodium influx, i.e. we inactivate the sodium channels, and then we allow the potassium efflux and some chloride as well. Potassium is going out, chloride is coming in. This is transient phase, very short. Phase 2. Calcium influx balanced with potassium efflux. What type of calcium channel? The L-type calcium channels. Phase 3, potassium efflux. Phase 4, as you know, the pump. Class 1 antiarrhythmic drugs, also known as the sodium channel blockers will inhibit phase 0, so they will prolong phase 0. It will take longer and the slope will decrease. And then phase 2 is blocked by class 1b. Phase 4 is targeted by digoxin, and phase 3 is by class 3. This is the easiest one to remember. Phase 3, class 3, the potassium channel blockers, such as the ugly amiodarone. Class 1 includes quinidine and procainamide. 1b includes lidocaine. 3 is the amiodarone, and there is another one called sotalol. Here's the best table ever. Phase 0, phase 1, 2, 3, and 4 channels. We activate the sodium, allowing sodium influx. What happens here? Rapid depolarization. Blocked by class 1 antiarrhythmics, also known as the sodium channel blockers, such as quinidine and procainamide. Phase 1, we inactivate the sodium channels and we allow the potassium efflux. This is transient repolarization. Nothing whatsoever can block it. It's very short. Why bother? Phase 2 is the plateau. Calcium influx, potassium efflux. This is the plateau. You can block it by class 1b to decrease the plateau, or class 3 to prolong the plateau, and this is crucial. Phase 3, we inactivate the calcium channel. We work only with the potassium efflux. This is called repolarization, like actual repolarization, and this is blocked by class 3, sometimes class 1, and this is the potassium channel blocker, such as the ugly amiodarone. There is another drug called dronidarone, and a third drug called sotalol, and you have dofetilide and ibutylide. You will hate yourself. Phase 4, the pump and the exchanger, the resting membrane potential. This can be blocked by digoxin, as I've told you before in video number 12. Class 1 and 3 affect the muscle of the ventricle. 2 and 4 affect the SA and the AV node. Let's talk about the SA node and the AV nodal potential. 4, this is phase 4, and then we start with 0. Cool. Where is phase 1? Doesn't exist. Where is phase 2? Doesn't exist. And then we have phase 3 and 4 again. This is very fast, and like there is automaticity here. However, phase 0 is not due to sodium influx. It's due to calcium influx, still the L type. And then in phase 3 we have the potassium efflux, as you know. Phase 3 is always blocked by class 3. Thank you. If this is a calcium channel, who do you think is gonna block it? Calcium channel blockers, also known as class 4. So in phase 0, we have calcium channels. We block them by class 4 antiarrhythmics, the calcium channel blockers such as verapamil or diltiazem. Phase 3 is by class 3, the potassium channel blockers such as amiodarone, dronidarone, dofetilide, ibutylide, and sotalol. And then we go to phase 4, the slow depolarization phase, the actual automaticity. As you know, sympathetic wants your heart to beat faster, parasympathetic wants it to beat slower. So, sympathetic has a vested interest in making this phase faster. How do you make it faster? You make it faster by increasing the slope. You increase the angle, baby, so that you can rise to phase 0 faster and then go down faster. Everything becomes faster when you do this. That's great. That's the sympathetic. But the parasympathetic goes like this. Let's do it with the green color. It slows the slope of phase 4, and then everything that follows is going to be slow. We got it. Thank you so much. All right. How about beta blockers and calcium channel blockers? There's phase 4, right? Right. And they are trying to make your heart slow down because they block the SA node and the AV node. So they have a vested interest in decreasing the slope of phase 4. So instead of your normal phase 4 going like this, now your phase 4 will go like this. Thank you, class 2 and class 4 antiarrhythmics. Sympathetic increases the slope because it increases the angle. Remember in mathematics, yep, the angle here was called theta, and this is the angle, baby. So this is theta. The greater the angle, the greater the slope. It's very easy. Sympathetic increases the slope, make it like this, and then parasympathetic makes it decreasing the slope or makes it less steep. Then we have class 0 calcium channels blocked by calcium channel blockers or class 4. Then class 3, the potassium by potassium channel blockers, which is class 3. And then we have class or phase 4 by class 2 and 4. Both of them decrease the slope. So in phase 0, sodium channels are inactivated. You have only calcium channels, the L type. And phase 3, you have the potassium efflux through potassium channel. In phase 4, this is the pacemaker current. You have the sodium-calcium influx and the potassium efflux. And this is responsible for automaticity. Here we have something called the funny current. Ha ha, hilarious. I'll tell you why it's hilarious, because like sodium and calcium going in the same direction, that's funny. and then potassium is going out, sodium coming in, calcium coming in, potassium coming in. Is that funny or is that funny? That's the funny current. This is what's responsible for automaticity. By the way, in an upcoming video number 45, I'll tell you about a drug called ivabradine. The mechanism of action of ivabradine is to inhibit the funny current. No one will remember that when we go to video number 45. Here is phase 4. Sympathetic increases the slope. Parasympathetic decreases the slope. How about beta blocker? They decrease the slope. Calcium channel blocker? They decrease the slope. In the SA node and the AV node, they decrease your heart rate. How does Mr. Sympathetic actually makes your heartbeat faster? I'll tell you how. We have like a reflex here, the baroreceptor reflex. Let's say you have hypotension. This will decrease the firing. Baroreceptor, we have hypotension here. Let's stimulate the sympathetic nervous system. So you stimulate the sympathetic will throw out norepinephrine. But since this is a nerve ending, it will not throw away epinephrine. Epinephrine, by the way, comes only from your adrenal medulla. This is the only endogenous source. And then it goes to your atrium, to your SA node, because it has automaticity. And then thanks to beta-1 stimulation, you increase the heart rate, increase contractility, and if you happen to be a vessel, I will vasoconstrict the arterioles to try to increase your blood pressure, because you have hypotension, man. We're trying to restore your blood pressure and back to normal. The exact freaking opposite happens when you have hypertension. Now you'll stimulate the vagus nerve, which is parasympathetic. This is M2 receptor, goes to the SA node to decrease the heart rate, decrease contractility, cause vasodilation of the arterioles and veins to decrease the blood pressure back to normal. Here is a quick question for you. Why does the nerve ending secrete norepinephrine? Why isn't it capable of producing epinephrine? Why is the adrenal medulla capable of producing epinephrine but not the nerve ending? I'll tell you why. Because the last step in making those catecholamines is to convert norepinephrine to epinephrine. To do that, you need an enzyme. The name of the enzyme is called phenylethanolamine N-methyltransferase. This enzyme is found in your adrenal medulla, but it's absent from your nerve endings. That's why your nerve endings cannot secrete epinephrine. They can only secrete the norepinephrine. However, your beautiful medulla can secrete both norepinephrine and epinephrine. Let's talk about refractoriness. Here, as you know, are the muscles of the atria or the ventricles. This is not the SA node or the AV node. Phase 0, 1, 2, 3, and 4. From here to here is called the action potential duration. Of course, this is the duration of the entire freaking action potential. And then from here to here, there is no specific name for it. Here we have something called the effective refractory period. Your heart cannot get stimulated here. And this is the relative refractory period. Normally, you cannot stimulate the heart here. But if you have a very, very, very strong stimulus, you can actually override the refractory period and actually stimulate another upslope, another phase 0, like this one. Here is another rule for you. Any drug that increases the action potential duration will increase the effective refractory period, called common sense, because this is part of this one. If you stretch this one, you'll automatically stretch this one. And it will also decrease the rhythm. Yeah, because when you take longer, you are slower, like the AKG. Let's say that I decreased your heart rate. The PR interval will prolongate. If you take longer, it means you are slower in rate. Great. What does refractoriness mean? You are refractory to stimulus. You cannot respond to stimuli. It starts just after the inactivation of the sodium channel in phase 1. After that, the longer the action potential duration, the more prolonged the refractoriness. Oh my goodness, this is profound. In the next video, we'll talk about class 1 antiarrhythmics, the sodium channel blockers, such as quinidine, procainamide, disopyramide.